So just the territorial acknowledgement, similar to what Todd has done. Treaty 6 territory, respect the histories, language, and culture of First Nations, Métis, Inuit, and First People of Canada, whose presence continues to enrich our vibrant community. So thank you. So some of the objectives of my talk today, so hopefully by the end of the presentation, you'll be able to recognize the breadth and depth of the child data, describe some examples of how the child data has been used through the lens of precision health, and identify opportunities for collaboration and research. So some of the funding that we've had through CHILD and CHILD Edmonton includes funding from the Allergen NCE, WICRI, of course, Alberta Health Services, CIHR, PolicyWise, Norlene Foundation, and Genome Canada. So I wanted to start off with what is precision health. It's been something that has been complicated for me. So hopefully this will provide some lens by which I'll explain the child data. So I first looked at the U of A precision health framework, and they describe it as using AI and machine learning to look at clinical, social, and biological data, looking at genetics, developmental, behavioral, contextual, environmental, and social factors to promote health, wellness, and prevention. So by that lens, I mean, child is really easy to argue why it's precision health, and I'll go through that. I also did look at a couple of others. So the Precision Medicine Initiative, so Barack Obama, when he was president, his initiative was to approach disease treatment and prevention that incorporates genes, environment, and lifestyle. And they subsequently expanded upon what do they mean. So they included metabolomics within that description. And then they said, well, environment should include your microbiome composition, and lifestyle would include health history and diet. That's precision medicine. And then the CDC talked about precision health as including precision medicine, but a little bit broader. That includes prevention and health promotion. So I'll be talking about how child influences answers some of these questions around precision health. But I'd be neglected if I didn't put this talk in the context of some of the previous speakers, and particularly John Bell when he gave one of the inaugural U of A talks on precision medicine back in February. So the things that I took away from John Bell's talk was that in his view, the next 20 years of healthcare is about more precision. So new taxonomy for classifying disease. And at least my take from his talk was that phenotyping, so these observable traits that we use to classify disease, is probably going to be the biggest gap in getting us from where we are today to more precision. He talked about early identification of disease and focused on 3: cardiovascular, mental health, and cancers. The first 2 are very common, and I'm going to speak to why that's important. He talked about data and AI-enabled decisions. You'll note that both the U of A and the Precision Medicine Institute, among others, have talked about big data. So taking advantage of large clinical data sets, digital pathology and radiology, and improved diagnostics such as polygenic risk scores. And finally, he talked about cell and gene therapy. So I'm going to talk a little bit about phenotyping and what John Bell talked about and how CHILD will relate to that. So he talked about how do we phenotype disease currently, and he talked about phenotyping that we do currently in terms of symptoms and signs based on histopathology. It's lab-based, what's your blood pressure, what's your blood sugar, organ-based heart failure, which really doesn't tell you anything other than that your heart is failing, and then genetics for some rare diseases. Cystic fibrosis probably is one example, and oncology. So he talked about the future of phenotyping as large omics, imaging, genetics, and genetic risk scores. And so what are some of the challenges in getting from here to there? So he said, well, one of the problems is that symptoms and signs, some of the things that we use for current phenotyping, are quite subjective. And that makes it difficult when you're using something subjective to go from current phenotyping to future phenotyping. Diseases change with time, and sometimes the environmental exposures influence your phenotype. So when I view this in precision medicine, then I say, okay, well, those 2 types of studies. There's the types of studies that you're going to do when you have rare diseases, and that's often going to be some sort of case control study, because conditions are often hypothesized to be monogenetic, so from pedigree trees. And then the population that you're going to study is going to be pretty relatively straightforward. The cases are going to be often easy to identify. You may need a multi-center study to do it because it could be rare. In my field, it'll likely be cystic fibrosis as the prototypical disease for this that was first identified using case control studies. The intervention, as it were, is going to be genetics, which is the most obvious biomarker to measure in 2021, useful for diagnosis, prognosis, mechanisms, separates and then give, but you then require a separate series of investigations to identify the interventions. So cystic fibrosis, we've known about Delta F508 for decades, but it's only recently that we've, through a separate series of investigations, figured out CF modulator to help treat the disease. And then pharmacogenetics, which is what we're doing in CF to match drug to the genotype. Metabolomics arguably is the first biomarker that we ever measured. So sugars, creatinines, we use metabolites for neonatal screening. We use metabolites for neonatal screening in CF. And then often genetics is confirmatory, which is what we do in CF. And then lifestyle on these case control studies often is unmeasured. So I think that's, a reasonable approach to rare disorders. And then the control is often 2 to 1, and then time of exposure is often minimally considered. So what do we do for common disorders? So it's often, we'll often use a cohort study. So it's because we think the conditions are often polygenetic, have gene-environment interactions, and the timing of the exposure may be important. There's 2 large types of studies. There's 2 study designs really within cohorts. So there's the large and shallow, and John Bell spoke to 2 of these, the UK 100,000 Genome Project and the Our Health cohort, the 5 million participants. And then there's the narrow and deep. So birth cohorts would be considered in the narrow and deep. So child with only 3.5, so 3,500 participants, ALSPAC with 10,000, the Dunedin cohort, which has been going on for 40 plus years with 1,600 participants. Other more famous cohorts, Framingham, Nurses Health, Whitehall study. There's a number of these narrow and deep cohorts as well. Interventions are the things that we measure, genetics and epigenetics, most studies, microbiome with some studies, variable timing of when they'll collect the microbiome, metabolomics with some studies, differing methodologies. So CHILD has been using mass spec. I believe one of the UK studies has been using NMR. And then lifestyle, again, variably measured. Controls, difficult because you need to balance the density of measurement versus the study burden. And then timing is explicit within the study design. It's a cohort. And so really what happens is there's a sampling is during critical exposure, but you sometimes don't know when the critical exposure is because that's the whole point of the cohort. So I'm going to contrast the large and shallow versus the narrow and deep. So the large and shallow, these are the studies that John Bell talked about. They're really omics focused with a lot on genetics. They do talk about mail-in biological samples. They do talk about lifestyle and questionnaires and linkage with health records. And that's a lot of how they'll get around the lifestyle part of precision medicine. Their strength, really power over a large range of health conditions with looking at genetics and metabolomics. And they can do a lot of embedded case control studies for specific conditions. Some of the major limitations is phenotyping because it's questionnaires and linkage with health records. You get around this limitation in phenotyping because you have a huge N. Often the lifestyle questionnaires are retrospective because they're recruiting adults, and it's a single generation. And so you contrast that with the narrow and deep. So omics again, extensive genetics, metabolomics, microbiome, lifestyle, self-report, physical activity, links with health records. So when I say physical, so physical, like we actually see them, do blood pressure. Some of the lifestyle large studies do that as well. Actigraphy, some of the large studies do that as well, but they don't do it all or a lot of it. So the 4 strengths, and this is what I'm going to highlight on for the CHILD cohort, is that they are often multi-generation. CHILD is 2. Some of the Dunedin is now 3. I think the RAIN cohort in Australia is a 3-generation cohort. Detailed prospective assessment of exposures, detailed phenotyping, and a nimble response to the research environment. The 2 biggest limitations of these narrow and deep studies, so you're only really powered for some common health conditions. If you only have 3,500 children, you're only going to be able to look at so many things. And then the multi-ethnic cohort, so for example, child cohort in Canada, limits your power for some genetic analyses. Okay, so I'm going to talk about those 4 advantages of these narrow and deep cohorts within the child cohort. So what is the child cohort? So again, it's the study of gene-environment interactions in utero, looking at the gene-environment interactions in early childhood, and then looking at clinical phenotypes, asthma and allergies, sleep, neurodevelopment, a lot of common outcomes. So who did we recruit? There's a number of choices when you recruit for a cohort study. The Dunedin cohort recruited at delivery. The Canadian Longitudinal Study of Aging recruited people, I forget the age, I think 40, 50, 60 or above, and then have been looking backwards through different generations. The National Children's Study in the US tried to recruit women before they became pregnant, and we recruited, in the child study, we recruited pregnant women. The study of families, because we're focused on genetics, we recruited both one child from family and the mother and the father. And of note, one of the major inclusion criteria was able to read and speak English, and were born at 34 plus 3 weeks gestational age or greater. So really not a study of prematurity, really almost term or term infants. It's been a national effort. We've recruited across 4 centers in Canada: Vancouver, Edmonton, on the site leader here, Manitoba, and Toronto. It's involved over 40 researchers across the country, over 100 healthcare professionals. It's really been a monumental task, but it's allowed me to work and interact with amazing people from across the country and worldwide, really. So we have had extensive visits with the families. Oops, sorry. So we saw the families when moms were pregnant. We did a home visit at 3 months of age, a clinic visit at 1 year of age, another clinic visit at 3 years of age, 5 years of age. We're seeing them now. We're just finishing off the 8-year visits, and we're now working on a 13-year visit, maybe a visit through late adolescence and early childhood or early adulthood. So in that way, these are long studies that have lots of assessments over time. And we collect a lot of data. We have looked at air pollution, the home environment, where kids in daycare, what's going on in schools, personal exposures such as smoke and pets and viruses, diet and nutrition, stress, and socioeconomic status, which obviously influences where families live. We've also done lots of omics work within child. So we've done genetics on child and mother, and we have funding to do the father. We've done cord blood epigenetics in some limited samples. We've done stool microbiome at birth, 3 months, 1 year of age, breast milk microbiome, stool metabolomics, so looking at the metabolites of the microbiome. We've done urine metabolomics here in Edmonton at 3 and 5 years of age on the children, blood metabolomics, and then we got a CHR grant to do viral immune profiling here in Edmonton. So lots of big data. So I highlighted 4 strengths of the child cohort. So a narrow and deep cohort study. The 4 again were detailed prospective assessment of exposures, detailed phenotyping, the multi-generational nature of the study, and then a nimble response to the research environment. So I'm going to highlight in a shallow and broad way how each of these 4 strengths of child have resulted in advancing our understanding of precision health. So the first one is prospective exposure of assessments. And that, of course, did not work. Oh, so here it is. So we've collected a lot of data. This is not meant to be read, but really to highlight that there's a whole bunch of questionnaires, tests and assessments, a ton of samples from 18 weeks gestation up until 8 years of age. So lots of prospective exposure data. In Edmonton, we've been really focused on sleep and neurodevelopment, and we have done quarterly assessments of childhood sleep and snoring from when the kids were 3 months of age. So we published a paper a couple of years ago now looking at sleep duration. And we showed that there is trajectories of how children sleep through the first 2 years of life, and that there's about 17, 18% of kids who are really these short sleepers, and then 25% of kids who are these long sleepers. And these short sleepers really are sleep below the actually Canadian recommendations. We also were able to then look at nighttime sleep trajectories through the first 2 years of life and show that 10% of kids really are these short sleepers that don't sleep for a lot of time at night. And we then showed that sleep trajectories are associated with language development at 2 years of age, and that those kids who really are those short sleepers at 2 years of age, or the short sleepers over the first 2 years, have lower language scores at 2 years of age. And then we controlled for, this is just showing the sleep data, that we did control for a whole bunch of other factors, including family history of language development. So really, hopefully this paper highlights how this longitudinal collection of sleep data, in this case, is associated with language. And we, of course, corrected for sleep at the current time point to show that this is a cumulative exposure. We then looked at sleep disorder breathing, so snoring, and looked at behavior. So we did a lot of behavior and neurodevelopmental testing in kids at the Edmonton site. And the things that we wanted, the focus for this talk, for this section, is around the child behavior checklist at 5 years of age. So we looked at trajectories of snoring through the first 5 years of life. And we showed that the vast majority of kids, about 79, 80% of them, don't snore through the first 2 years. That's not unexpected. There's a group of kids, about 5% of kids, who persistently snore through the first 5 years, and there's a group that are late onset, about 10%. So we looked at behavior problems among these different trajectories. And we showed that those kids who have persistent sleep disorder breathing symptoms have an increase in the CBCL score at 5 years of age. And this is significant when you control for current symptoms, physical activity, a whole bunch of other things. And really highlighting that, just this cross-sectional assessment of do kids snore, which would be the current SDB category, really doesn't get at the impact of 5 years of snoring, or the contemporaneous, are kids snoring now but not before, versus early onset, are the kids snoring before and not now, and their influence on behavior. So really, hopefully this highlights that the timing and understanding the timing of these things matter. This is externalizing behavior, similar results. So the next area of focus is on the microbiome. And again, looking at timing of exposure. So CHILD has a strong focus on microbiome. We've done gut microbiome, breast milk microbiome, house dust microbiome, and looked at asthma, obesity, and development. And I'm going to highlight 2 of those outcomes here, so asthma and neurodevelopment. So we have a couple of papers on the gut microbiome as it relates to asthma. And what we showed, So what we showed was that the 3-month, there were 4 family of microbiota coins flavor LVR for Faecalibacteria, though I'm going to pronounce these terribly, Lachnosbriae, Rothia, and Villanella were associated, but that at 1 year of age, those 4 family of bacteria were not associated with the development of asthma, really speaking to the fact that timing of exposure, in this case microbiome, matters. We then validated this in a murine model to show that the flavor-induced attenuation of murine airway inflammation, showing that early, if you give them this murine model of these 4 family of bacteria, you can attenuate their airway inflammation. Sorry. This worked before. And then in a separate paper, we showed the mechanism by which these 4 family of bacteria influence atopy and asthma, and it's through small chain fatty acids, in this case butyrate fermentation. Again, this is looking at metabolites of the bacteria. So the second outcome I want to highlight is microbiome clusters associated with cognitive development. Again, does the timing matter? So in this case, we also again looked at 3-month and 1-year microbiome, and we found that the 1-year microbiome was associated with behavior or with development, but really it was clusters of microbiome together that really mattered. It wasn't these 4 specifically, that it was a different set, and that individuals have a cluster of microbiota. And that when you look at cognitive development using the Bailey scale at 2 years of age, it was the microbiome at 1 year of age and which cluster the child was in that determined their cognitive outcome at 2 years of age. So the next area of focus would be on detailed phenotyping. And so for the detailed phenotyping as a second advantage of the child data is around, so we did wrist actigraphy, so measurement of objective measurement of sweat, step, and sleep in kids. This is the kind of data that you get when you do wrist actigraphy in kids. So over 200 million data points, and you get these sleep graphs which show physical activity and nighttime sleep. So we looked at screen time, sleep, and physical activity on behavior, and we showed that 83% of kids met the sleep recommendations, 50%, this is pre-COVID, I wouldn't even hazard a guess of what the screen time recommendation would be now, but at that time, 50% of kids met the screen time, and that using objective data, so physical activity data, about 20% of kids met the physical activity data. So looking at meeting the guidelines, the Canadian guidelines, if children met none or just one of the Canadian guidelines using objective data, they had an increased probability of, they had an increased total problem score on their CDCL. You know, a lot has been made about machine learning, and so you have 200 million data points for the actigraphy data. So we used a machine learning approach to look at sleep. And specifically, we looked at hidden Markov modeling for sleep states at 3 and 5 years of age. And we showed that at 3 years of age, there are 4 sleep states using actigraphy. And then at 5 years of age, there are 6 sleep states. But really, we wanted to operationalize that data. And so we were able to bring the data down to 2 sleep states. So a sleep state where children are not moving, HMM1, and a sleep state where there's some movement during sleep, so HMM movement. And we showed that in all children within our cohort that sleep states really didn't matter. Total sleep actually didn't matter either, and it was really a little some function of sleep latency or how long did it take for the kid to go to bed. But we showed that in kids who have sleep disorder breathing, actually the time in sleep without movement mattered, and the more hours that they slept in sleep without movement, the lower their behavior scores. And that among children without sleep disorder breathing, none of these things really matter. And really, the detailed phenotyping allows us to start to understand why do children with sleep disorder breathing have higher behavior problems. All right, so multi-generation. So really, the advantage of this multi-generational cohort idea is around this hypothesis or this developmental origins of health and disease. So what's this DOHAT thing? So it's an exposure to specific environmental exposure during a critical period may have significant short and long-term health consequences. So the environmental exposures typically talked about include nutrition, infections, chemicals, and during critical periods would be prenatal to early childhood. So, it really was an evolution from the Barker hypothesis, who showed a long time ago a positive correlation between birth weight, a surrogate for fetal undernourishment, and ischemic heart disease in several studies, UK, US, Sweden. Of course, the Barker hypothesis has come under criticism. Is it really nutrition, or is it stress or adolescent obesity or whatever? But really is one of the early papers to argue that exposure in multi-generation matter. So I'm going to highlight where that's important where CHILD has shown that to be important in 2 areas. So looking at early maternal exposure through diet and maternal exposure through air pollution. So the diet data we've published 3 papers looking at maternal diet during pregnancy and outcomes. We've shown it within CHILD with my colleague Francois Balduc in the fruit fly model, and then my colleague Clayton Dixon with the rat model. And then maternal diet again with BMI through a paper that my colleague Megan Azad published in JAMA Peds. So the cognitive development piece, the child data, sorry. So the child data, we showed that maternal consumption of fruit during the first, during pregnancy, the more servings of fruit, the higher cognitive score at 1 year of age. And I, of course, said this feels like a correlation and must not be really real. And if it was really real, we would be able to find it in some other model. So I asked my colleague, Francois, to do some fruit fly work because I would be able to find the answer in 28 days. And he came back to me and he said, you know, it actually works. I don't know if he actually said it like that because he has his French accent, but it was some version of that. And he showed that when we provide fruit flies with orange juice and tomato juice, because we had shown that lycopene as one example was important, that the fruit flies had improved learning and memory. So then we we also showed it in Clayton's rat model that prenatal fruit exposure impacted memory, but not learning in his rat model. So, you know, this one observation within CHILD, which I thought was actually just going to be spurious, have been able to replicate within a fruit fly model and within a rat model. And I think that's a nice example of where you can take observations within cohorts, and we'll get into a couple of other of those subsequently. Sorry. Okay. So the other exposure around nutrition is around weight and BMI. And so Dr. Azad looked at maternal gestation of sweeteners, artificial sweeteners and sugar, and infant BMI and overweight, and showed that an increase of maternal artificial sweeteners is associated with an increased infant BMI score. So this is maternal gestational sweeteners and overweight. So the air pollution data, so we published a paper looking at air pollution, epigenetics, and atopy. And we looked at prenatal traffic exposure, traffic-related air pollution exposure, the gestational epigenetics clock, so using some of the cord blood epigenetics data, and early life allergic sensitization. And we showed that, you know, early life traffic exposure causes an epigenetic deviation in your cord blood gestational clock. And that clock is associated with your risk of atopy. It revolves around this hypothesis in allergy and asthma that you have an accelerated maturation of your immune system that then results in an increased risk of atopy and asthma because you start to view early infant exposures, such as peanuts and whatever, in your immune system views them in a different lens. Okay, so being nimble. So the SARS-CoV-2, sadly, we all are living that at the moment. So, you know, we took the child data and an opportunity to look at seroprevalence among 8 to 13-year-old children. We recruited child study participants, apron participants, families, and we showed that 1.2% of children were positive or borderline positive at the first blood draw, which is really a reflection of the first wave. And then that 3% of children were positive through the second wave of the study, so some longitudinal data. And really the study funded by the Alberta government really took advantage of the fact that we have participants recruited as part of CHILD already, an apron, and can we start to look at seroprevalence without recruiting a whole new cohort. And these participants were not recruited based on whether they had an exposure or not, so really giving a general sample population representative view of what's going on in the community from a seroprevalence perspective. Okay, so collaborations and opportunities. So, you know, I hopefully have not highlighted these types of papers in epidemiology that we looked at risk factors for disease, or we used a fancy method, so we're going to make some causal claims, or that we shoehorned COVID into our overall research. But really, I want to highlight, hopefully, the potential for collaborations. I've highlighted some analysis of the child data, but there's actually 3 areas for links to other for potential for collaboration. I'm going to highlight 3 of them that CHILD has already done. So links to other cohorts, validation with administrative data, and validation with basic science data. So the links to other data, so you'll note that both the shallow and broad and the narrow and deep talked about polygenetic risk scores and disease. So CHILD has looked at polygenetic risk scores, but because of the way the power was structured, we partnered with the Saguenay-Lac-Saint-Jean asthma cohort and looked at a polygenetic risk score, and showed that we are able to, with the 2 cohorts together, determine a PRS score. This is not meant to be like consumed in the, oh, I totally understand this, but like we looked in the testing cohort and a validation cohort, and then tried to create a binary PRS score to determine kids at risk for MSAD, in this case is moderate to severe atopic dermatitis. So this is meant to be more an example of how you can take multiple cohorts of data to be able to look at genetics in this case. The second thing that we talked about is validation using multiple models, and I spoke to it using the prenatal fruit data, but Dr. Azad took her non-nutritive sweeteners data. So just to highlight that, so maternal non-nutritive sweeteners beverage consumption during pregnancy, the more you have, the increased risk of child BMI at 3 years of age. And then they did some mouse model work looking at sucralose and aspartame and looking at BMI, or sorry, looking at weight, but also looking at adiposity and adipose tissue. And then they did a cell model work. This is definitely not my work, which is effect of sucralose on adipocyte differentiation, and showed that outside of the group C, which is just late exposure, that all these groups that had early sucralose exposure had differences in their differentiation of adipocyte tissue. The second area where we talked about is mapping the administrative, is validating some of the child observations using administrative data. So child study, we showed that infant antibiotic use increases your risk in the first year of life, is associated with the increased risk of asthma at 5 years of age. This all relates to that microbiome idea in your first year of life. The more antibiotic courses the child has, the greater risk of their asthma. And so we wondered if that was actually reflected within the administrative data. We have been seeing a decrease in asthma prevalence over time, and I've often wondered, is it related to smoking or what? And so what we showed was that as antibiotic prescription rates have decreased, asthma rates have also decreased, and that in this population administrative cohort, as the annual antibody prescribing rate has increased, your risk of asthma increases as well, controlling for the year, sex, particulate matter, which is also significant. And we have other papers to highlight that as well. So again, taking the child data and then looking at administrative data and kind of mapping the 2 together makes for, I think, stronger conclusions. So none of this work would happen without a whole bunch of people. So lots of my students whose data I presented today, the child study staff, and I've been privileged to work with many collaborators across Canada whose data I've presented today. But again, none of this work happens without the child families. And so I'd like to thank them for their dedication to 13 years almost of being part of the study. And with that, I'm happy to answer any questions.
Thank you, Piyush. For those who have questions, either just pipe in or put them in the chat. I have several, but I think the first one, and a bit cheeky one, with respect to the short versus long sleepers, did you, I mean, as a parent, did you find any things that predicted what would make a child a long sleeper? I think that's what we would all like to have, right, is longer sleepers. So yeah, did you look at that piece?
So that is, one of my students is looking at that piece. We actually have extrapolated that data out to 5 years of age and are looking at that. So not yet, but is on the books.
The other piece, with respect to the COVID data, I mean, you showed us that you have a 3% prevalence in the second wave and whatever it was, 1 point something in the first wave. Could you talk a bit about what predicts a child getting COVID? Like, were you able to identify risk factors?
Yeah, so we have looked at that. It's unpublished data, but what we looked at in terms of seroprevalence was that kids there was this interesting interaction between masks and gatherings, and that kids who attended more gatherings, if they didn't wear a mask, their risk of being seropositive was increased. If they wore a mask and went to fewer gatherings, then their risk was pretty negligible.
So wearing masks works.
Wearing masks is associated with a lower odds of being seropositive.
Okay. Did you see in the chat box, there's a question?
That saliva and teeth samples from parents. Yeah, so that's a great question. So, the teeth data came about because there's a group of investigators who are interested in metal exposure, and teeth are a great repository and environmental exposure of that nature, and we're interested in that. We did not gather oral history data, if I'm understanding your question correctly. But I mean, hopefully this is where people can say, well, that data, kids do go to dentists, and we have linked with other data. Can we not ask parents to link to their child's dental data and go talk to dentists and get their data? So I think that sometimes, the cohort does not need to ask the question in the questionnaire to actually answer the question. There are other ways to get the data. So if that's something you're interested in, happy to work with you on how to start to get that data. Certainly the CHILD study in all the sites in Edmonton specifically has an opportunity to talk to families about being able to link to other data. Pharmacy data is another example.
Did you see the next question, Piush?
For the COVID study, from first to second wave, we're able to determine where the infections were acquired from and what the rate of asymptomatic hospitalization rates different. So these were kids that were not recruited because we have a separate group of kids who are recruited that were seropositive or PCR positive, but these kids by and large were not recruited because they were positive. So the vast majority were asymptomatic. Where the infections were acquired. Oh, so I think, and I didn't publish it, I presented that separately. The vast majority were not known. And if they were tested, it was because they were a contact. But don't quote me on that, Sunil.
There's a
which others, yeah. So, and yes, we would like to publish or at least have the data in some peer review. This is okay before we do create a lay summary. On that though, we do have an active parent advisory committee that we are always looking for people who are interested, because these studies don't happen in a vacuum. They happen with families, and CHILD is trying to answer questions that are important to families. I mean, the COVID one is an obvious one, but we asked the screen question. I didn't actually present any of the screen data, but we asked and answered this question around how much screen time is too much screen time, because a whole bunch of parents, when we said, what are you interested within CHILD? What would you like CHILD to answer? They said, well, is my child watching too much screens? And we said, well, we have the data. We should analyze the data and be able to answer that question. And so part of CHILD's goal is to answer questions that are relevant to Canadian families. So I'm inviting you to be part of the parent advisory committee, but if not, yes, a lay summary, but a lay summary is in the works.
Did you see Ahmed's question?
So Ahmed, the question around preterm birth, so there's two answers. The first, there actually is a group at the U of A who has a cohort of preterm birth children. that they've been following for decades, since I was a resident, actually. And so they have fantastic data. But the other reason why they were excluded is because the original focus of the study was on asthma and allergy. And we know that preterm infants have different risk factors for development of respiratory symptoms, not necessarily asthma and allergy, but they're confounded. And so that's why they were excluded from the child cohort.
What's the name of the preterm birth cohort that you're referring to?
You know, if I'm, Matt Hicks will know, because he runs the clinic, I think.
Okay, just so Amit can find it if he's interested.
Yeah, Matt Hicks should know. I think Charlene Robertson started it like she was really a forerunner in this. Okay, so is there any recruitment efforts for new participants? So, you know, I'm putting in a grant to Whitbury, actually, but to start to validate. So we actually have a paper that's under review where we created a score to predict emergency C-section. You know, there's all that microbiome data. We created a score for prediction of kids with snoring and the risk of behavior problems. But one of the challenges with all of those things is you need to validate them. And we've done some validation work, but what one of my proposals is to create a less intense cohort, so not so deep, but to start to validate some of the findings within child. I do think that needs to happen. And I think, you know, child's been going on for 13 plus years now. We have enough data from different phases of life that we could validate a lot of our findings. So yes, yes. So I'm getting started on a study with Apron, have there been collaborations between child and Apron? So on the COVID part, yes, there is some other work that is being done with I forget his name, one of our collaborators on epigenetics out of UBC. And actually, does Child Study have data regarding blood tests during pregnancy? Can get through linkage, but haven't got. Mike Coburn, thank you, that's right. Mike Brower does our air pollution work. Okay, so are you thinking of the needle follicle? That's right. That's right. Okay. Other questions?
Yes.
So one of the things that Child is really interested in while there is a lull is collaborating with people. There's a whack load of data. And so, like, you know, there's no shortage of people who want to analyze child data. And I think that's good. That was the first of the collaboration piece. But I think taking they were excluded on it. Is data captured. So mothers who have children born from major IVF strategies were excluded, again, because they probably would have different risk factors for asthma and allergy. So Child wants to collaborate. I think hopefully the collaborative studies that I've highlighted are studies where we take the child data and not just analyze the child data as another, like, hey, we showed this association, but like really take the data and say, well, we showed this association, but cohorts are great at finding associations. What about animal model work or population level work or using replication through other cohorts? So a lot of genetic work through replication is how a lot of the genetic work happens. They show it in one cohort and then replicate in another. And that's really what I'd like to see, is that we work with, there's lots of people at the U of A and others who have cohorts or other sets of data. You know, the collaboration, I think Child can act as amazing controls for other people's cohort studies. There's a question around, are all parents biological to the child? At recruitment, they were. Obviously, family structures change over time. And so the families have changed over time.
I think we're 5-2, but just a last thing. if people want to access data, there's a mechanism. What's the best way? And if people want to know what data you have, say they want to test a hypothesis because they found it in an animal or whatever,
Yeah.
how do they access the data? Can you just tell people and so put them
Yeah,
towards?
so email me one way, go to the childstudy.ca website, and there is a way for people to start the conversation with the child group in general. There's of course an intake form that says, well, what's your question? How are you proposing to answer this question? And what's the methods by which you're planning on doing it? And wild is child unique, especially if you want biological sample data, then one of the first questions is, why do you need longitudinal data? And why do you need child data? So if it's like, hey, I just found this and you have easy data, that probably is not going to fly. It has to be something where you're like really like it has to be something where child can really make a difference. So you're studying blood groups as a variable. So have not.
Given the history, it's probably worthwhile and easy to do, I would imagine.
Yeah, I don't think we've actually, so when we measured, so with the way we really tried to make that study as least intrusive as possible. And so we measured serology and we collected just one gold top tube. I don't actually know if a gold top tube is actually going to be the right tube to measure ABO.
Anyways, you can think about it. I think that's probably good. We can give people a couple minutes back of their day. Maybe they get a chance. They say they use EDTA for ABO.
Yeah.
But anyways.
I'm happy to speak with you, Anne, and Lori offline.
Okay. You can get it from Serum. But anyways, I think thanks for the questions. Thanks for the talk, and very interesting data coming out of a massive cohort and undertaking. And another way to do precision medicine, I think, or precision phenotyping. And I thank you for your time, and hopefully it was informative for people today. It certainly was for me. And with that, I think our next one will be in the fall in September. So I'll see you guys. Well, see many of you before then, but hopefully we see you at the next one then. Take care.
Thanks again for the opportunity to speak and present the data. I really appreciate it.